representatives from the state governments and the private sector to critically examine how AI-enabled solutions are being implemented within public health systems, identify key constraints to scale, and articulate what an enabling ecosystem for responsible AI in health should look like at the state level. The discussion will focus on implementation experience, system-level challenges, and institutional pathways that shape AI adoption in real-world public sector settings. I would be introducing the chair and esteemed panelists one by one. I would request the esteemed panelists and chair to join us on the stage. First and foremost, it is my honor to introduce the keynote speaker and chair for the panel today, Ms. Punya Srivastava. Ms. Punya Srivastava joined the Indian Administrative Service in 1993 and is currently serving as Secretary in the Ministry of Health and Family Welfare, Government of India, leading initiatives aimed at improving public health and healthcare delivery. We welcome you, ma'am. It is my pleasure to introduce our distinguished panel today. I extend a warm welcome to Dr. Sunil Kumar Barnwal, a distinguished Indian Administrative Service officer of the 1997 batch, currently serving as the Chief Executive Officer of the National Health Authority. I welcome Shri Sampath Kumar, an Indian Administrative Service officer of the 1997 batch, serving as Principal Secretary and Development Commissioner to the Government of Meghalaya. I welcome Dr. Piyush Singla, an IS officer of the 2012 batch, currently serving as Secretary of the Information Technology Department, Government of Jammu and Kashmir. I would also like to welcome Dr. Geeta Majnunath, the founder, CEO, and CTO of Niramai Health Analytics. I would like to welcome Dr. Anand Sivaraman, CEO, Remedio Innovative Solutions. Now, I would like to extend a warm welcome to Shri Kiran Gopal Vaska, who will be moderating the panel discussion today. Shri Kiran Gopal Vaska is an Indian Administrative Service officer of the 2008 batch, currently serving as the Joint Secretary and Mission Director of the Ayushman Bharat Digital Mission at the National Health Authority. Thank you, sir. With this, I hand over the mic to Shri Kiran Gopal Vaska, sir, to moderate the panel discussion today. Thank you.
Thank you, Devika. I once again welcome the chair and the panelists to this very important panel discussion on scaling AI for public health impact through public-private partnerships. This panel is an extremely important panel where we tried to bring together senior experts, seniors from both the public and the private sector, mainly to focus on one point, that we may have the best of models, we may procure the best of the compute, we may have the best of the ecosystems, but the winners in this AI world are the ones who actually start implementing and using them at scale. And especially in a country like ours, where we have a varied populations requiring different kinds of, having different kinds of constraints, it is essential that we bring down the cost of expertise. We bring down and we democratize services, health services to the last mile. And using AI effectively becomes very, very important here. So through this session, we expect to explore a few themes and understand how we can develop a shared understanding of what enables responsible AI at scale within state health systems, because ultimately it is the state governments who implement the systems, generate practical insights on transitioning AI-enabled solutions from pilots to sustained implementation, because we just don't want to run small pilots and then lose sight of what's happening. Then highlight procurement, governance and institutional challenges on how we can translate a solution from a pilot to a scaled implementation. Identify some best practices, that is where our states can give us that ideas, and inform future policy development on how we can go about sustaining these efforts and efforts of enablement at the state and the national level. So with that, I request the chair, Srimati Punyasrila Srivastav, Secretary, Ministry of Health and Family Welfare, ma'am, to kindly give her keynote address and set the tone for the panel discussion, ma'am.
So, good evening, everybody, and a warm welcome to the panel discussion today. Before we delve into the questions that Kiran has posed before us, I thought it might be a good idea to sort of give everybody here, because some of us might be new, some might be old to the landscape of health ministry, and give a brief idea as to what is the progress that we have made so far, at least from the perspective of health ministry. So, as you are aware, over the past decade, our entire health system has undergone a steady digital transformation. We all began with digitizing records, improving the data reporting, and now we have the interoperable digital health ecosystem at a national scale, the Ayushman Bharat Digital Mission. The National Health Policy had set the goal before us that we have to ensure the highest attainable standard of health and well-being for all citizens. And it is this vision that the National Digital Health Blueprint of 2019 was building upon. And it has laid out the essential principles for India's digital health ecosystem based on this policy directive. And therefore, this blueprint promotes open standards, enables interoperability, adopts emerging technologies such as Gen AI to strengthen service delivery and enable early disease detection while ensuring privacy at every step. So many of you would have looked at the Ayushman Bharat Digital Mission. It is interoperable, it is open, it is a standards-based digital system, and it has actually evolved into a comprehensive health ecosystem for better service delivery. And why I'm saying so is that this is something which has been demonstrated time and again, whether when we look at our data which is being captured through various portals, or when we looked at the 11 crore footfall that we had during the Swasth Nari Sashakt Parivar Abhiyan. The ABDM has been proving very useful to us at every stage. And today we have 859 million citizens who now have Aadhaar accounts linked to more than 878 million health records across the country. I do hope everyone in this hall has an Aadhaar ID. If not, please make it today. So with the expansion of our primary healthcare network, some of you might be aware the sub-centers and the primary health centers that we have upgraded them into what we call the Ayushman Arogya Mandirs or the Ayushman Arogya Kendra. We have now 180,000 across the country. We have the e-Sanjeevani, the telemedicine facility, which is being provided at each of these centers. We have the AI-assisted clinical decision support system, which is assisting the telemedicine platform. And it has facilitated over 449 million consultations through over 2.2 lakh registered healthcare providers. So all of these make India's telemedicine initiative, I think, amongst the world's largest in primary healthcare. Our numbers are humongous, and therefore our systems do get tested for their robustness and their ability to deliver. We are also, of course, promoting the adoption of clinical decision support systems in the private sector under the ABDM's open standards and responsible generative AI frameworks. And my request in every gathering where private sector hospitals and health facilities are there is that do join the ABDM. It will prove useful to all of us in the long run and to each one of us as a citizen as well as a health facility. So digital systems enable us to capture, store, and transmit information. AI, as you all are the experts here, now allows us to interpret, prioritize, and act on it more effectively. And therefore, one of the key expectations from AI, especially in public health, is that it should reduce the burden on our healthcare workforce, complementing the physician-patient relationship that remains at the heart of healthcare delivery. And therefore, the question before us is, can AI help bridge these gaps? You must be aware that every time, at least till a few years back, we came up with a new digital initiative, there was a lot of resistance that we will need to do a lot more to do this. So that's why we keep on talking about how to make the lives of our healthcare workforce easier, especially in the governmental systems where the public pressure is really high. You have a 15,000 OPD in Safdarjung, you have another 15,000 OPD in AIMS. So expecting everyone to use the system means that I need a system which assists them in the way that they would like it to assist them. We have, with support of some of you who are there in this hall, we have the Madhu Netra AI under the National Diabetic Retinopathy Screening Program, which is allowing non-specialist health workers to capture retinal images. I'm told it has benefited over 7,000 patients across 38 facilities. That means we can decentralize its capability. Similarly, in tuberculosis, the AI-enabled handheld X-rays are being deployed for early detection of TB, and we have been using it very effectively, and state governments have been demanding more and more of such machines because such equipment, and we think it is contributing to the decline of incidence of TB in India. The cough against TB is also being used. Over 1.6 lakh individuals have been screened using this tool. You are aware about the AI-enabled tools such as the media disease surveillance system, which is there with our integrated health information portal platform. It helps me a lot, at least, and it helps our entire NCDC team, because not every incident gets reported even by the vigilant state governments. So the AI-assisted media alerts do help us. We have also established 3 centers of excellence for AI in healthcare: AIMS Delhi, PGI MER Chandigarh, and AIMS Rishikesh. So our primary objective is that we prove that AI can work in the real world public health settings. So that's why we need to design it with clear objectives and integrate it into service delivery so that people come saying that we want more of it, and we have to avoid any kinds of flaws in it so that it can become inclusive and affordable while being very robust and effective. So I would be very keen to hear from our participants that what are the challenges that you face while working with the government systems, and how can our processes, procurement models, or data frameworks evolve to enable more effective collaboration while following government norms. That is the challenge often with many of us here, that how do we follow our norms and at the same time get the best, most effective system for our digital solutions. Then from the states, I would of course like to hear their feedback on the AI solutions that they are using. Which have they found most useful? Which have they found difficult? Which have they found flawed, if any? What is the support they would require from the union government? The teams are here. We have been trying to work on policy. We have been trying on, would you like more technical docs from us? Financial support in what way? That also is something that we can see. And how can we ensure a smoother adoption and a scale up across the diverse health systems? So I really would like to hear from the panelists today and from some of you as to what we can do ahead. I would just like to emphasize that the cornerstone of this discussion has to be the principles that have been laid down by the Honorable Prime Minister Narendra Modi ji. He has been emphasizing that the digital public infrastructure is a tool for inclusion and equity. Therefore, whatever we are doing in digital health and AI is an extension of that commitment. And ultimately, as many of you are aware, we are all working with a goal of Viksit Bharat at 2047. And we feel that whatever discussions that we have today and over the next few days can do have an impact on enabling us to achieve our goals. With this, a big thank you to all of you for coming here, and a thank you to the participants. Let's start the discussion. That was pretty long. I hope not too long. Okay, thank you.
Thank you, ma'am. That was optimum from a time point of view, and you've given us the whole canvas of what the government is doing, what efforts have been ongoing, and where we are already seeing some results. And this sets the tone for the further discussion going forward here. Now, I come to our first panelist, my CEO, Dr. Sunil Kumar Banwal. Sir, AI is here, and it is the new general purpose technology that can revolutionize a lot of areas, and healthcare is one of them. So, sir, from a perspective of looking at how this can transform and how we are going ahead, I'd like to understand from you and also the panel, the audience here. And if we look at 5 years ahead, what would a mature AI-enabled public health ecosystem in India would look like? And what must we do differently starting today to get there?
Thank you, Kiran. I think Madam has set the tone, what all we are doing in the healthcare using technology. AI is something which has been added in a big way, and it is going to actually transform the whole healthcare delivery. Let me tell you how it is going to work in next few years. 5 years time has been given. The point is, if we take AI as a standalone innovation or a technology which is going to just help you or enable you, I think we are not harnessing the full potential of AI. So we need to move from project or a scheme kind of implementation to actually create or enable an ecosystem development for using AI in healthcare delivery. When I say ecosystem development, we see there are so many players who bring value in the healthcare delivery. It's not just the government or the government institutions. There are private institutions, there are private healthcare professionals, there are health tech companies, there are innovators, startups. Everyone brings value in the system. Now, if we just take it as a project, I don't think we will be able to actually leverage the full potential of AI. So that is one part. And second, we should not be treating AI just one additional help. It has to become part, or rather get embedded in the healthcare delivery. So it has to become integral part of it. As Madam also mentioned, it should not be just a tool which just, like we moved from paper to a digital, we needed, from typist to a data entry operator. So something like that is not a great value addition. Rather, if it reduces the whole, work of the healthcare professionals, whether it is a frontline worker or it's a doctor or a nurse, I think then only we can actually take full advantage of it. And that is going to happen if we see AI in two ways. One, we all see AI will improve the clinical efficiency of the treatment, whether it is, cutting edge technology, robotics, etc., etc. On the other hand, see how much workflow improvement it does in healthcare delivery. Like even if we know there is a highly specialized doctor, how much time does he spend only on treatment and how much time he does non-clinical work, which includes listening to the patient, writing prescriptions, and doing many more administrative work. So these all can be done away with if we really integrate AI in the whole workflow completely into the healthcare delivery system. And that can happen if we actually work on standards. And the architecture should be open, interoperable, and that is what Ayushman Bharat Digital Mission is doing. So when we talk of deployment of AI, even if the data is not centralized, its application can be there across all the facilities. And this is what we are looking at. If we really want to develop and harness the full potential of AI, we need to actually develop the ecosystem rather than using one or the other isolated solutions. And that is what is being done when Madam spoke about the clinical decision support system integration in the telemedicine. Because it automatically becomes part of the healthcare delivery. People come for the treatment. The doctor or the whoever is the frontline worker will see based on the symptom what could be the possible diagnosis. So this is what I think should be done in next 5 years. We should be enabling ecosystem development where every player in the AI, innovation, development, deployment, and monitoring, everyone plays a very creative and effective role. Thank you.
Thank you, sir. Building an ecosystem is the key, and that will actually help us harness the full potential of AI for better healthcare. So now I come to Sampath Kumar, sir. Sir, you are heading the health department in the state government, and you are the one who is overseeing the delivery of healthcare services in the state. And when some solutions come to you, earlier it used to be digital solutions, simple, plain digitization. Now there are AI solutions. So, sir, when solutions come to you, or when somebody comes to you with a solution saying, look, there is a problem, so I have a solution for this. So, from a state implementation standpoint, sir, what are the AI use cases that have been easiest to operate? And what are the reasons? I mean, what is enabling them, that you are able to use them and scale them? So what are the characteristics of such solutions?
Thank you. Thank you, Kiran. And thank you, ma'am. And my colleague, my batchmate, Mr. Sunil. And also all the panelists. Thank you for this opportunity. I just wanted to reflect on what you said. In fact, as Madam also said, the states have a responsibility for implementation. So one of the things actually what, in Meghalaya, especially what we have been trying to do is that how do we leverage the AI for effective implementation of the programs? Because one of the challenges for the states is that while we have, I think all of you are aware, we have massive programs, massive national programs. We have a lot of resources. In fact, I would say there is no dearth of resources. There is a very good intent is there in terms of implementing the programs. What actually the states really look at is that how effectively we are able to do this. Are we able to achieve the purpose for which actually these programs have been designed? So what we did a small experiment. I wanted to tell 3 use cases so that how actually we did this. We started actually way back in 2020 during the COVID period. We started actually looking at our data of especially the maternal deaths. We have a huge maternal mortality rates. So then when we looked at the data, we were collecting the data, but we are not effectively using the data to analyze the data and how actually we can solve the problems. So what we did was actually we not only taking the data that is coming from the HMIS, we should also collecting the data why actually the challenges are there. We also started collecting the socio-economic determinants, and mapping all the data put together, and started actually having an analysis, why actually a mother is actually, has, come to this kind of a very, stage where actually we should have prevented. So while doing that, what we could able to, by effectively using the data, we could able to, give that capacity to the front line that, here is a mother, she's a multi-gravida, she's also poor, she's also living in the hard-to-reach area, she needs to be actually brought to the health facility well in advance. So a simple, what I would like, basically a prediction with much more data. So once we started actually using this data, we could able to see like, there is a tremendous, motivation for the, frontline functionaries in saving lives of mothers. In fact, we could able to reduce maternal deaths by over 50% in the last 5 years. So that's one use case I would say. In fact, our Honorable Chief Minister has written about this one recently in the Indian Express, after the regional AI summit that has been held in Shillong with the NHA and World Health Organization. So what we have been saying is that by what we are seeing is that the using the data, effective use of data and analysis of it actually helping us in solving the problems. That is the key thing. Then the second use case I would like to share is that like, we also have tremendous challenge in terms of specialists. In fact, all over the, country might be there is a challenge, but Meghalaya has severe challenge. We don't have specialists, enough specialists. So when it comes to like a TB, I think as Madam has already mentioned, we have used a beautiful use case, handheld X-rays. Last 2 years, 90,000 people have been screened. And using the AI, offline AI data, we could able to identify who actually needs, like a radiologist, the AI is doing like a radiologist. And we could able to identify about 110 positive cases, and we could able to put them on the treatment. So one second important thing is that like it has to help the states in terms of solving the problems. In fact, we did a cost benefit analysis of this particular solution that we have actually used for for TB. In fact, we actually saved 4 crores in terms of the transportation cost. If we have to bring all of them to the radiologist for a, it would have costed that much money. So this is again a second interesting use case. And third thing that I would like to share is that electronic health records. In fact, this is again, this is our Honorable CM actually tells this one. We need to reduce the administrative burden of the doctors. Doctors actually have a huge administrative burden. How do you reduce the administrative? In fact, my CU NHA was mentioning how actually AI can be used for reducing administrative burden. So what, for your question, just like to sum up is that we, whatever, basically what we look at is that like what is actually useful, what is purposeful. I think that actually we will try to experiment through a process, we call it like problem-driven iterative adaptation approach. You test it and see how it is functioning, and you modify it and implement it. Thank you.
Thank you, sir. Yeah, PDIA it is, problem-driven iterative adaptation. Absolutely, sir. I mean, so basically the use cases that are easier to operationalize are the one where the state finds value, where the state's problems of finding specialists or helping solving other problems or the administrative burden are chosen, are identified, or they're able to solve those problems, then both the administration and the political executive are able to help solve and take that solution on board. So basically, a problem or an AI solution has to create value. So now with that, I come to the private sector participant, private sector panel here, Dr. Geeta Manjunath from Nirame. Dr. Manjunath, you are now, have been running this this organization that is providing AI-based solutions. So from a private sector perspective, I'd like to hear from you, what are the main challenges private companies feel while working with government health systems in terms of procurement timelines, data access, deployment at scale, or even long-term sustainability, or any other challenge that you want to highlight? Basically, what we have seen is, yes, there is a beginning when you come, you speak, then we say, okay, let us try it out in 1 or 2 hospitals. After that, what? So what are the challenges you're facing, and how do you think, what are those issues that if you raise that can be addressed so that this transition from lab to pilot to scale can actually happen?
Thank you very much for that question. And it's really, really wonderful to be part of the AI Impact Summit and full house. And it shows the amount of excitement AI has created. And that too, sort of, for enabling good public health, right? Use of this technology. So just sort of 2 minutes on what we do so we can relate to the answers. So yeah, I lead a startup called Niramai. In this forum, I'll say niram.ai, so it sounds better, where we've developed a new method of detecting breast cancer. We just measure the temperature variations on the chest using a thermal sensor, infrared imaging device like one of these cameras, and convert 4 lakh temperature points, which kind of are proxies to the tissue activity at different points on the breast, and convert that automatically into a breast health report. So in a rural area, you can use this. A simple health worker can be empowered, just like click photograph types. And the AI actually provides triage, red, yellow, green automatically. And obviously, it's a screening test. People who are high risk need to be taken for further diagnostic workup in terms of imaging like mammogram, ultrasound, MRI, whatever is needed. Because, it's a very, very big problem, and we know the affordability, accessibility issues, and so we end up losing every alternate lady to breast cancer. That is 50% mortality, right? Who has got detected with breast cancer, every alternate lady dies. So really early detection is important. So we've kind of made this work. It's a new innovation made in India, and now we've been able to, oh my God, thank you so much. We have made this, with multiple state governments. We have collaborated, including Punjab, Karnataka, Maharashtra, now Meghalaya also, sir. Actually, last 3 months we are running with Meghalaya as well. Wonderful effect there, Uttarakhand, many, many places we have done. So coming to the question that you asked, Kiran sir, is first and foremost, I think, starting off a pilot with a state government. Because health is a state matter, right? Every state officials we need to sort of impress upon and, convince them that the solution works. So it's kind of fragmented, we would say, the decision-making process. Now, next is, obviously, pilots have, so I'll be very, and it's a wonderful opportunity to keep cribbing, sorry, but please take it in the right. Really, it's a huge opportunity, that's why. So next, of course, we need to find funds to actually do the pilots, because first few pilots have to be free, right? But of course, some states have been benevolent in trying to sort of allocate funds even for pilots, so maybe we figured out how to do that, working with the government officials. So for that, again, we'll have to find, and it has to be large scale. So as a small startup, it's difficult for us to fund those things. And I think there's a lot of knowledge gap, and I think ma'am mentioned, sir, you gave a lot of information about what government is doing. But if you look at it from a startup founder perspective, we don't know how to sort of get to that, right? There is Arogya Mandir, 180,000, it's amazing, right? I got the numbers wrong maybe, but somewhere around that, right? But how do I get to that? It's really a dream for many of the founders here, I'm sure. How do I get into those, right? At least 10 of them, then I'll make it 100. So that pathway is not clear, ma'am. If there is some pathway, like it could be a governance body, which takes, we won the National Startup Award, we've won many, many awards, but that doesn't get to the pathway, right? So what is that rule or the process to get into this? That's not very clear in our minds, and probably there is one, but it's not communicated to the right people who are innovating, is what my knowledge is. Many times also, we can do pilots, we'll get funds. For the large-scale adoption, we understand there should be some kind of a program funding. We have to create new programs to get the funding for it. Looks like some of the people who are working very closely with the government, like distributor type people, they know exactly where the funds is and so on and so forth, right? But it's still for the full scale up. Again, if we don't know, we are just stuck doing pilots. I'm really sorry. Maybe it's an obvious one for you, but it's really killing so many innovations from scaling is what I feel, right? Now switching to AI per se. We do AI on thermal imaging. We don't manufacture thermal cameras as such. It's a pure software as a medical device. And many of you here, again, appreciate how AI has grown to make an impact for clinical decision support in healthcare, is that it can just take images from MRI, CT, X-rays, like ma'am mentioned, TB, for example, all of this. And so it's an image in and result out. So it's a simple software. So many people are like, okay, how can a device be just a software, right? It's an AI is a medical device, right? It has to have a touch and feel. Obviously, there's a hardware which is attached to it. And so should we really pay for it? Just for software you want to pay. So these kind of, notions come in. But of course, now it's getting better. We say, okay, here we have done and this is happening. Prior usage will definitely help there. And the third part I want to mention is for preventative. We all know that prevention is definitely better than cure. Especially for cancer, early detection can cut down the treatment cost by 10 times, 20 times, maybe 100 times also, right? So if you can detect in stage 0, stage 1, versus a stage 3, stage 4, which is what is happening today. Most women are detecting their cancer by hand. The screening rate for breast cancer with mammography in India is 1.3%. 98.7% of people, ma'am, are detecting their cancer by hand. And even the resource constraint settings, WHO guidelines is do clinical breast examination, hand-based examination, a little bit more trained. So why can't we use AI AI with affordable devices that, many of the innovators like ours do, so that we can detect early and save on treatment cost and so on and so forth as well. So in this case, I understand that PMJY, for example, Ayushman Bharat and all, basically are mainly for treatment, So maybe we should have a preventative care budget as well. I can go on and on, but I think, but it's really wonderful to be on the same stage as, decision makers and people who are driving this. And voice, it's not just my opinion, it's the opinion of so many such startups that are out there trying and wanting to make a difference to the public health. Thank you so much for the opportunity.
Thank you so much, Dr. Manjunath, for that very candid answer, where the whole idea of having to convince the state government that this solution works, finding the funds for the initial pilots, which most of the time we expect to be done for free, and the knowledge gap. I mean, how do we tell the private sector that, okay, look, these are the facilities available, this is what the government is already doing so that you can complement us better. And then the whole idea of bringing in preventive care into PMJY is also very, very useful. Thank you so much for that. So now we move on to our next panelist, who is a doctor, but heading the IT department of Jammu and Kashmir. So that is a very deadly combination when it comes to AI in healthcare. And Piyush is a good friend, and we've known him from earlier. So Piyush, you are now in the department that drives technology in the states. And the startups would in fact be first identified by you. I mean, they might be coming first to the IT department, and then how you link them up with the concerned department, be it health or education or any other department matters. So from a state government perspective, how do you think states are positioning themselves as ecosystem curators, where they are bringing together academic institutions for research, the private sector for innovation, and public systems for real-world deployment to translate AI ideas into actually scalable and market-ready solutions? So we'd like to hear from you on that.
Good afternoon, all the esteemed panelists, and good afternoon, everyone, one and all in the audience. I think what ABDM has done, it has set up the framework beautifully for the states and UTs to implement. Various interoperability standards and other issues which normally states will struggle for standardization has been beautifully rolled out. But I see states and UTs at this point of time as conveners, not just implementers. because real public health challenge, the data, the issues which are prevalent on the ground, the disease burden on the ground, they can convene various kind of stakeholder consultation and come up with the solution. In J&K, we recently had one discussion with ICMR to set up one computational health unit. So I went to an institution as a pre-AI summit, SKIM Sora in Srinagar. So what was amusing was the enthusiasm from the medical fraternity. They equally want to learn what are the new AI models, how to come up with the solution. So I see them as a very important stakeholder. So now we are in discussion with IIT Jammu, one of the HEIs present in Jammu and Kashmir, to set up a computational health unit, so that based on the priorities of the local disease burden, the local data availability, the total, we know the challenge of the data fragmentation available, we can come up with a certain set of brainstorming with the available infrastructure, and then accordingly pick the use cases which are actually relevant for our disease burden. Rather than as a knee-jerk reaction, we do not just want to push AI to any use case which comes our way and will not be very useful in the longer run. So this is one strategy we are adopting, and we have been giving public notices as well as inviting various startups to please come up, discuss, be our partners in the overall discussion, and the National Health Mission has been equally on board for all the discussions. Second, importantly, we saw a gap which we want. We are trying to fill it, is the learning from the medical facility vis-a-vis the technical expertise. I see a lot of doctors, they want to do many AI courses. So they were very interested, where can I do this course, data mining course. So when I went to the SKIM Sora, tertiary care center, I think the audience, almost 10 doctors must have said, I want to do one data analytics course. So that was very amusing. I discussed with Kiran sir, and good to learn that there are initiatives already taken, and we can link those up. Thank you.
Thank you, Dr. Piyush. And I think this collaboration, or the lead that you as the head of IT in the state is taking in building this computational processing unit, I think will go a long way in placing the state, in readying the state for using AI much more effectively. So now we turn to our next panelist, now from the private sector, Dr. Anand Sivaraman. Dr. Anand, basically Dr. Manjunath told you about the challenges, told us about the challenges of the private sector trying to operate in the public sector space. What I want to understand from you is, what role can private sector play beyond technology? Because at the end of the day, and as we have learned through in a hard way through implementing ABDM, that it's not just about building the backbone or getting an HMIS solution. It is also about the change management. It is also about training. So what do you think the private sector can bring beyond technology, such as training, change management, capacity building, as far as government systems are concerned, especially in healthcare? And with your experience where you've rolled out the AI-based solutions for eye health, I mean, if you can please tell us what are the ways in which this collaboration between the private sector and the states can go beyond just procurement of technology, so that that bond becomes much more stronger. Please.
Thank you so much. Wonderful being part of this panel. And just to tell you a little bit about Remedio, the organization that I'm part of, what we solve for is the problem where in rural areas you have one ophthalmologist for 2 lakh people. And how do you now think in terms of a smartphone-based device that takes high-quality pictures of the retina and is able to screen for chronic retinal diseases? There are around 300 million at risk in India for that. How do you actually task shift that to health workers? That's problem statement number 1. So the hardware device that we built that is completely indigenously developed here in India, today we have around 3,000 of those in use in India and around 1,000 in the US. So it is a case where it was built for the health worker in Kerala, in Meghalaya, but now is also being used by primary care physicians and nurses in the US as well. So it's something that was built for India, but has allowed us to go global, thanks to the fact that that is possible. The second part to it is you solve for the problem with respect to imaging, but how do you now solve for a specialist? So that's really where the AI comes in. So in 2019-20, when we got into it, we realized we didn't have the NVIDIA chips, etc. at that time as mature. But we realized that we cannot do anything on the cloud because the cost was going to be expensive. So we developed what are called privacy-preserving algorithms that work on the smartphone itself. And within 5 to 10 seconds of taking an image, you're automatically able to see whether or not the patient has diabetic retinopathy, glaucoma, macular degeneration. And what has been amazing about that is, again, showing what is the advantage to all of us as founders. What India really gives us is the same algorithm developed here. It's so resilient that when NHS in UK actually tested these algorithms on 1.2 million images in UK, we came out to be the best among all international global AI algorithms with the best balance of clinical sensitivity and specificity. And thank you. To a large extent, this is made possible because when you design under constraints in India, you are able to get the design right that it is globally relevant. That is one key part. For example, we had to train the images on actual images that are taken by health workers. They are not going to be of the same quality as what you would get inside an ophthalmologist clinic because their hands may shake. But how do you build a resilient AI algorithm that is able to still detect disease in spite of not being offered the best images is really the problem that I think India as a nation can solve for the world in population health screening. Now coming to the key question, what is it that we can? So what we did was we worked very early with the government of Kerala as a sandbox where we brought in the solution there, the hardware. And at that point in time, we worked very closely with one of the health systems globally that has eliminated blindness due to diabetic retinopathy, which is the UK NHS. We realized we can't create programs around technology because there would be a conflict of interest. So they designed the programs, but the government of Kerala implemented it. And what was interesting is we not only published the results, 99% of those that were found to have a problem did not know that they had a problem, so which was the big one. The second was from a health economics analysis perspective. Again, this is published, where we showed that there was an 85% reduction in the cost of screening, which was the second part that we were able to look at. And the third part is really around, we come at it from a public health perspective because after screening, you still have to ensure that there's a loop closure in terms of care that happens once you detect there is a disease. So one of the models that we did is how do you therefore link public health centers to district hospitals where the treatment is actually made possible, and how do you now create registries? Because in chronic disease, it does not matter that you just screen once. You need to screen every year. But now how do you create registries? How can you create governance guardrails around how this registry is kept? All of this was actually part of what happened. And in fact, the nice thing is after the entire 7 lakh screenings that we have gone through, we've actually had ABDM PMJ now. Geeta, to your point, ophthalmology conditions, diabetic retinopathy, glaucoma, and ROP screening is now reimbursed as part of ABDM PMJ, so that any physician, and this we have to really give it to the government where they didn't restrict it to ophthalmologists. They said that any physician who would use any technology, it doesn't matter whether it's ours or anybody else's, and are able to detect the disease, there's a reimbursement for them. So this came about thanks to a lot of the evidence that came in. So really a great step forward there. Now, what are the challenges? 3 key challenges. One is I'm going to talk about what I felt we should do as founders or companies that are part of it. We need to work with the government, not transactionally in terms of a tender. We have to work in terms of how do you build programs and sustain programs with them. That is very, very important because I can tell you that the business interest of the private sector is also in terms of doing this. I'll give you an example of it. The first 16 centers around Trivandrum is where the pilot was done. It was part of an Indo-UK grant. And thereafter, it was scaled to 250 centers. But what we had to do was build capacity. You had to go there and make sure that you build capacity because the capacity will be different in different family health centers. Not every health center will be the same. So it's important for the private sector to get into programmatic delivery where you are going to be responsible in a way to help build capacity, build dashboards by which you can actually show utilization rate. Because I'll be very honest, there were some centers where the devices were not getting used as much as what we would have expected epidemiologically. But by giving dashboards, there's a way by which you are able to show the program managers what the actual utilization is, and you can actually go in and solve for problems. In fact, now what we are moving to is moving to models by which can we incentive align everyone, including the private sector in it, where you don't go for capital equipment-based sales, but instead can you start looking at how much everyone earns on the basis of a person screened, which now aligns everyone in the pathway, creates this as a program that's for a long term. And there I agree with Dr. Panwal where he made the point on ecosystems, because I feel that is very, very important. The other way by which I think we need to look at this differently is when we first went to the government and we got feedback saying that, look, can you look at I not as part of a separate program, but as part of NCD? So what that meant is we went back and said, what else can we do with that one retinal image? Can we start looking at CT calcium score as predicted from the retina? Can we start looking at cardiovascular risk along with chronic kidney disease risk? Now what happens automatically is the amount, the 85% reduction now goes to 99% because now for the same test you're able to detect more in the population. So that was something that where we had to redefine the problem of what we are working on the basis of the fact that when you have that one screening event, how do you actually make sure that you're able to get as much as possible out of it? So I think to summarize where I think the private sector really needs to play a role is look at this as a public health problem, not as a problem of selling devices into. And I think that is something that we have learned. We have benefited from having a public health team within the company that is responsible for looking at utilization rates after we place devices. And I think it's really helped us understand the problems like what Dr. Banwal talked about in terms of how do you fit into workflow? How do you make it simple for the ASHA worker there? The health worker, she has hundreds of things to do. And you have to make it simple enough for her to do it. And that only happens if you look at it as a public health problem, not as a business problem of selling devices, which I think is the key thing that all of us would take well from it. It's helped us. We've been able to scale. The second opportunity I feel is once you're done in Kerala, you have to repeat now with every state. Instead, I'm hoping that with the publications that come out, it's a way by which there may be a translation of technology that happens. And the last part is the ecosystem part that was talked about. I think that's very important. When we took our algorithms through CDSCO approval, there was no predicate device. We were the first to go through it. So it took us around 3 years. But now we are a predicate as a result of which there are 2 more solutions that have come. And I can tell you that it's not competition. The more we are able to get more people into this ecosystem of AI-based solutions, I think the awareness goes up. There is enough of a market. And more importantly, from a public health perspective, we have 300 million people that we have to actually prevent blindness in. So that's really how we got started and how we see the role of the private sector when it comes to what else we can possibly do. Now expanding to systemic diseases from blindness.
Thank you so much, Dr. Anand. That's a very, very, a different way of looking at how a startup should engage with the government. I mean, this whole idea of not looking at a relationship from a purely transactional point of view or purely selling a device point of view, trying to build the solution around the problem, help in post-implementation, I mean, after the rollout and further evaluation, and if only publications can help us in procurement, nothing like it then. I hope it leads to that one day. So before we come to the chair for her way forward and concluding remarks, I have one question for the CEO. Because, sir, by putting AI and within health and saying that, yes, all states will now be trying to implement the solutions, we are also setting a cat among the pigeons saying, okay, now there is generative AI where everybody thinks they have a solution for everything. So many a times we see people coming saying, I have a solution, do you have a problem? Right. So, sir, in such a situation, we also need to make sure that the solutions that are getting developed are interoperable, transparent, explainable, and aligned with public health goals. So how do you think, sir, we need to make sure that this also happens along the way while we are adopting more and more AI solutions into our systems?
Yeah, when we talk of AI solution, as long as we are doing, proof of concept or the pilot, I think it is fine to experiment with it. But when we talk of AI solution to be implemented at population scale, it has to follow certain guardrails. And that is where I believe in case of whatever AI solution we use, it there has to be certain things which should be inbuilt it. Like it must have, governance has to be by design. There cannot be deployment and then governance. So something like that, it has to pass through the trust and also have a privacy by design. So if these things are kept in mind and also make arrangements where, data, security, consents are all gets inbuilt into the whole mechanism of implementing AI, it makes a lot of sense to scale up at the population level. But two more things are very important when we talk of AI in healthcare. It may not be true with many other sectors, but when we talk of the healthcare, which is extremely sensitive, and people just can't risk their life based on somebody else's assessment of efficacy or accuracy of the solution. So at that point of time, it is very important that we see that not AI takes decision, rather it helps human in the loop to take decision. So it should not be replacing the technician or the doctors. It should be actually enabling or multiplying the capacity of the doctors to deliver more. So if we are thinking of an AI solution to deploy at population scale, this has to be kept in mind. And last but not the least, the AI solution should actually mitigate inequity and the bias. This is something which we are finding, and there is a lot of research or ideas which is coming. Many a times it promotes bias, it builds inequity. So if we are talking of an AI solution at population scale, this must be built into the system much before it is deployed. And it not should only be at the beginning of deployment, also should be monitored throughout its life cycle. So AI deployment is not just one-time affairs. It has to be the whole life cycle, and that is where our role is very important. And I think Ministry of Health is working in that direction, that how should we have, and therefore we are coming out with a strategy for AI in healthcare exclusively, which will actually set the framework in which AI deployment, implementation, monitoring, and even decommissioning can take place at appropriate time. So I think this is which I feel is very important when we talk of AI, particularly in healthcare.
Thank you so much, sir. So now, ma'am, we'd like to listen from you about way forward and your concluding remarks.
So I think the way forward has come out very clearly through this panel discussion. So Sunil has already laid down the fact that we have to view the ecosystem as a whole. And I think Dr. Anand brought it beautifully, that the solution has to address the public health challenge, and it has to view the challenge as an ecosystem. So a solution has to be viewed in a holistic perspective, because only then can you succeed. I think we in ABDM and in NHA will have to work out, maybe have a brainstorming session and work out whether it's possible to lay down certain pathways as guidance documents. So if we can do that, then I think that might make it, some states are of course doing fantastic work, most are doing, but maybe laying down the possible pathways and where the challenges come and what are the possible ways to address those challenges, which Dr. Manjunath also brought out. What could be the possible ways to address that challenge is something that we need to see. Then, of course, regulatory capacities. So I think a regulator is missing amongst us, but the regulatory capacities, how do we enhance it? The more we do, the better it will become. So it's a kind of a generative system in itself. So that is also which will require the attention. Then, like in the ICMR, we have a health technology assessment. So supposing her solution has come and she has got the regulator's approval, whether from public health perspective, does it make sense to bring it there? not just in terms of cost effectiveness, but also in terms of its implementability, we'll have to see. So presently that is seen on one hand by the Health Technology Assessment Board of ICMR, and on the other hand by our NHM team. That if we upscale it, is it implementable? Will it make life easier for the ASHA worker or tougher? And will she do it or will they not do it? So we don't want a fancy solution out there which nobody will use. So I think those are the things. Then maybe a registry of possible solutions. I may be using the wrong word. You're free to use the right words. But if this registry is available, then maybe it can help. Then under the NHM, because a lot of us are talking about public health perspective, which is largely through the flagship program, we have sharing of best practices regularly, and sometimes it does help states in adopting each other's practices. So once you have the registry of solutions, maybe in every regional conference or national conference that we have, one section could be devoted to the AI solutions, which NHA could compile and present. So that may also help integrate the whole thing.
Thank you so much, ma'am. I would like to thank the chair and all the panel members for their valuable insights. And over to you, Devika.
Thank you, sir. Thank you to our esteemed chair and panelists for a deeply engaging session. Now, I would like to request Dr. Sunil Kumar Barnwal, CEO NHA, to present a token of gratitude to Ms. Punya Srivastava, Secretary, Ministry of Health and Family Welfare. Thank you, sir. Thank you, ma'am. I would now request Shri Kiran Gopal Vaska, sir.